the early and late complications following breast reconstruction, doing it this way. The word complication has come up very often since ADM have been introduced and TRMs have been introduced. The complication has been mostly tissue ischemia and necrosis, infection, seroma, and capsule contracture. As you've seen in the meta-analyses and the publications that I have compiled with you, actually it was compiled by Moon Nahabedian, who is the breast editor at Plastic and Reconstructive Surgery Journal, and it has shown clearly that using an ADM of sorts, or tissue reinforcement matrix of sorts, there are no more complications than when doing a total muscle coverage with an implant or a tissue expander. Yes, there are more ischemic complications in direct-to-implant surgery in one stage versus 2 stages. However, the advantages of the technique in hands of surgeons who are experienced with that, and Andre, you adjust at the third of the learning curve, 10 patients. You need 30 patients to go beyond the hard part of the learning curve, and then you start doing fine. This is a series that we have published last year of 341 consecutive, immediate, direct-to-implant breast reconstruction in 210 patients with a bovine-derived ADM. Highest incidence of complication was necrosis in 5.2% of patients. Seroma was in 2.6% of patients. Infection was in 2.3% infection, and failure was in 2%. Every patient that had a failure had necrosis, seroma, and infection. No one just out of the blue all of a sudden failed. No one. Capsule contracture had 7 patients out of 300, 7 patients out of 210, 2%. We speak only about grade 3 and 4 capsule contracture, which is the objectionable hardening of the breast. All patients with capsule contractures were irradiated patients. So if you look at this series and other series, okay, overall the success rate is very high and the good results outweigh the complication a big way. Why do we have this issue of ischemia and necrosis primarily? Because we deprive the skin of the breast from 2 of its major blood supply, from the intercostal and the pectoralis major muscle blood supply. So we are left only with a blood supply that is diffusing around from the skin around the breast. That's where we get our blood supply. Since this skin is thin, sometimes traumatized, and sometimes unreliable in its ability to envelope and hold the implant, we tilt the pectoralis major forward, we suture an ADM or a tissue reinforcement matrix, and we put an implant. Thusly, the weight of the implant is totally cradled by the tissue matrix, and the skin envelope merely sits over it. So when you have a patient like that, where we did a skin-sparing mastectomy and she had a wound breakdown, we proactively treat her. We take her to the operating room, we excise the margins, and if we can close it with no tension, we will do so. So here she is after that. Above, this is before having, she had a 2-stage. So tissue expander and some wrinkling, below definitive implant and some fat grafting. Or a patient like this. The inframammary fold approach is the most difficult approach, but the nicest to take the breast out in a nipple-sparing mastectomy. However, it is your non-dominant hand or your assistant which will crush the skin or the subdermal plexus of the lower pole and cause skin necrosis. When you see a patchy skin necrosis like that, this is caused by the retractor of your non-dominant hand or your assistant. This can be easily treated with a laterally based thoracoepigastric flap from the upper abdomen in order to close that, and it has saved us in situations like that many times. The laser Doppler camera, which is a simple, friendly, usable camera, has helped us to assess skin viability in those patients. So it's a camera that is so small, you bring it over an arm to the operating field and you read the perfusion at a reference point over the abdomen where you do not operate. And then you navigate it over the breast and you can see the staples in the camera so you know exactly where you are and you see how well your perfusion is. It is therefore that large necroses and ischemia like that are history. Those are things of the past. And even when we had those, we would proactively take the patient back in the operating room, excise the skin, put an expander in instead, and save the reconstruction. Seroma is the #1 complication of tissue matrices. We're not sure why. Is it the foreign bodies, implant and matrix? Is it the ischemia and the foreign body? All we know that there, at the time you put your last stitch, begins a race between adherence and disaster, between adherence and failure, between adherence and seroma. If it doesn't adhere to the overlying skin envelope in 10 days, 20 days, then it's probably going to fail. What is responsible for that? Is it the physical properties, the thickness of the matrix, the pore size, or maybe the product isn't so inert as we think, because sometimes we get acute inflammatory reaction. To treat seroma, we use a seroma cath, which is a little gadget that helps you introduce a venflone into the pocket without stabbing the implant. This has been published both by Cordero and Clemens from MD Anderson and Sloan Kettering respectively, and it shows that the incidence of complication is much higher in irradiated patients. Interestingly, they show that in patients who had post-operative radiation, the incidence of complication is much higher than in patients who had previous radiation. All radiations are not the same. You have to befriend your radiation oncologist and talk to him about your patient. Share with him the specifics of this patient, mastectomy and reconstruction, where she is thick and where she is thin, where she has muscle and where she has ADM. With our radiation therapists, we have shown, as you'll see in a minute, that if you reduce the homogeneous dose, you avoid the hotspot to the implant tissue interjunction, you reduce a daily dose, and you give 1.2 grays with maximum implant dose of 15.4 grays, and you give no boost to small tumors, you will have a very low incidence of grade 3 and 4 capsule contracture. So out of the 341 breasts that I've shown you before, 57 had been irradiated. 9.3 prior radiation and 7.3 post-operative radiation. 7 of these 57 patients developed grade 3 and 4 induration capsule contracture, which is 12.3%. When you compare it to a historical group of patients who had the same operation with no ADM, 52% developed grade 3 and 4 capsule contracture. Coordinating radiation with an implant or ADM breast reconstruction is exciting because it has taught us that planned post-operative radiation therapy is not a contraindication to immediate implant ADM reconstruction. Prior radiation with no clinical evidence of radiation damage, pigmentation, induration, atrophy, telangiectasis is also not a contraindication. However, this group, in our experience, the group with prior radiation carries the highest incidence of complications. And the reason is that some of these patients have been irradiated 20 years ago, 15 years ago. You don't know how they were irradiated. You don't speak to the radiation therapist. And sometimes the tissue looks innocent, but it isn't. In our series, the highest complication rate is in this patient. And therefore, what we have changed in the last year is that in this group with prior radiation, we don't do direct to implant. We do a two-stage. And then every time you think that you know or you suspect that this particular patient is going to have radiation therapy post-operatively, try to do the definitive operation right there and then. Do not put a tissue expander. Put the definitive implant in. Why? So you don't have to operate on irradiated tissue later. Because radiation tissue is unforgiving. Radiation tissue is a problem, and if you can avoid operating on those patients, don't operate. So use the definitive implant. Sometimes you can't, because there's not enough tissue to cover a definitive implant. The blood supply isn't good to cover a definitive implant, so you put a tissue expander in. How do you deal with that? You have two options. One, if the radiation therapist, oncologist, gives you enough a window of time to exchange the tissue expander into a definitive implant before the radiation, do the exchange before. But if he doesn't, present to the radiation oncologist the tissue expander which is not maximally expanded. Present it to him soft. Let him irradiate the patient. Bring the patient back 2-3 months after the completion of radiation therapy and do a preliminary session of fat grafting to the tissues without exchanging the tissue expander. That will do two things. It will thicken, it will add more padding and softness, but also with the stem and regenerative cells in the fat, it will recede some of the radiation damage that was caused by radiation. Then bring the patient back again 2-3 months later, do another session of fat grafting and exchange the tissue expander. This is a way to prevent those complications that occur in the presence of operating in a prior irradiated patient. So, infection is the last issue that I'd like to deal with, because that is certainly a very difficult issue to deal when you have a foreign body. So in augmentation mastopexy and asymmetry correction, infection around a breast implant between 1% and 5%. In delayed breast reconstruction between 5 and 15, and in immediate it was 10 to 38%, which is totally unacceptable. Infection may appear not only 48 hours, but sometimes 3 weeks and more post-op. If you have a non-tuberculosis mycobacteria, onset is as late as 6 weeks, and it is difficult to diagnose. We'll talk about it a little more in a minute. When you have a delayed infection, months or years after that, after your reconstruction, it's usually related to something else. Urinary tract infection, upper respiratory tract infection, a flu, dental work. We tell all our patients that if they have a urinary tract infection, they should tell their family physician that they need to have antibiotics because they have foreign bodies in them. Or when they have a root canal, they should have antibiotic coverage and so on. Otherwise, they may get bloodstream infection onto their implant. Infection may present as a subtle event, a little redness, a little pain, no fever, etc., or like a very dramatic emergency with a big abscess in their breast, and they may show up septic. For the patient, it's always a dramatic emergency. Implant loss has a far-reaching psychological effect on the patient. The patient-doctor relationship are stretched. It is often a source of medical litigation, and reimplantation so far has failed in 50% of the patients. I'm here to tell you that all this can be changed. How? If you downgrade the stages of infection. Infection shows up first as level 1, pain, redness, and swelling. Level 2 is that plus discharge. Level 3 is that plus fever. And level 4 is that plus dehiscence. You need to downgrade the level of infection by getting culture and starting on oral antibiotics immediately, by switching to IV antibiotics within 2 days if they're not doing well, by taking them to the operating room, lavaging it, exchanging the implant, draining them, and putting them on the appropriate antibiotic, or if nothing else, remove the implant. If you start acting proactively early by downgrading the level of infection, you will do well. You should not start them on antibiotic without getting a culture first. You can get a culture by putting a venflone inside, and you can put a venflone inside by using a seromacath or any other gadget to get into the cavity before you start them on empirical broad-spectrum antibiotic. What's important to retain here is that surgical exploration is as important as IV antibiotic therapy. It will not go away if you don't explore these patients. I say don't drag by waiting and waiting, and don't drug them with antibiotic. Do something surgically to look at the pocket, clean the pocket. If there are granulation tissue in the pocket and pus, take the implant out. But if you don't see much, take tissue cultures, exchange the implant. Always don't leave the implant. If you have a tissue reinforcement matrix and it's not adherent, take it out. Put a new implant in and hope for the best. Washing the pocket also with Chlorosep, which is troclosan, is an organic molecule which is pH neutral. It releases molecule on demand and it oxidizes microorganisms. Very good to bacteriostat almost any bacteria. We have done that. Mycobacterial infection are the devious and the more difficult to treat because they appear 3 to 6 weeks post-operatively with no systemic effect. There's very clear serous drainage from the wound, and unless you ask specifically for mycobacteria, you say they get an answer, no, the culture is negative. So it doesn't respond to antibiotic therapy alone. Surgery is mandatory, and if you look at the literature, reimplantation surgery fails in 60%. We have changed that. We have waited, we took the implants out, waited 4 to 6 months until the tissue has returned to normal self. We then take a biopsy from the most dependent tissue of the breast, make sure that is clean, then exchange an implant and use Vicryl plus sutures, which are also triclosan coated. With this, in the last 10 years, 10 of us in my clinic followed 12 patients that had infection after both aesthetic and reconstructive. 8 patients had immediate postoperative some sort of operation. All were treated that way and salvaged. In 6 patients that had mycobacterial outbreak, we have done the same thing and have saved all of them, or were successful in all of them after 6 months to a year of explanting and reimplanting without default, which has changed the way we look at the literature. So, changing the course of infection around breast implants is prevented. Act immediately if it happens. Always get culture before you start antibiotics. If you start antibiotics, be it PO or IV, allow maximum of 48 hours for improvement, and if they don't get improved or get worse, move to the next step, which is early surgical exploration. Thank you very much.